Yeah, Nitin, start.
So 1 minute.
Okay.
Good evening, sir. Good evening, everyone. Myself, Nitin Gaudkar, and I will be presenting the case for lump in a breast. So let's get started. Demographic data and chief complaints. 50-year-old female patient, Lobabai Shinde, resident of Shirur, Latur, laborer by occupation, Hindu by religion, and belonging to the lower socioeconomic status, came to the OPD with the complaints of lump in a right breast since 1 year and associated with pain since last 15 days.
Okay, next.
History of presenting illness. My patient was apparently all right when she noticed a lump of size of a pea in her right breast in upper outer lateral quadrant 1 year ago, which was insidious in onset and gradually progressed to the current size of a ball. Lump is associated with the pain since last 15 days, which was also insidious in onset, continuous and throbbing in nature. There is a history of recent weight loss. There is no history of rapid increase in size. There is no history of similar swelling in the opposite breast. There is no history of discharge from nipple, any redness or warmth of breast, no history of any wound. There is no history of similar complaints in family. There is no history of early menarche or late menopause. There is no history of nulliparity. There is no history of absence of breastfeeding. There is no history of any radiation exposure. There is no history of bone pain or back pain. There is no history of breathlessness or cough. There is no history of swelling of arm. There is no history of abdominal pain or lump. And there is no history of night sweats and fever.
Yeah. Okay. Yeah, Nitin, proceed.
Yes.
So basically, your patient is a 54-year-old female patient. Okay. She is a resident of Latur, laborer by occupation, Hindu by religion, belonging to lower socioeconomic status, came with OPD complaints of lump in the right breast since 1 year, associate pain since last 15 days.
15 days.
Okay. Nitin, why
Yes.
this age is important?
Sorry, sir.
Why age is important?
Uh, age is uh, the breast carcinoma is commonly seen in age 45 to 55 years. And in younger age, there are benign conditions like fibroadenoma. So,
Okay.
based on age, we can uh, uh, guess the condition or we can investigate uh, in directions. Like
Okay. One is younger age, you will get fibroadenoma. Okay.
in younger age, yes, sir.
So what is Andy?
Andy means aberrations in normal development and involution, uh,
Okay.
which are uh, aberrations in normal development of the breast throughout the life. Uh, in the age of 15 to 25 years, there is a lobular development of the breast, which can, uh, uh, or we can say that the aberrations in that particular age may be fibroadenoma and in age of 15 to 50 years, there are cyclical changes occurring in the breast. So the conditions like uh, some cystic disease like fibrosis, cystadenosis, and phyllos tumor, or like abscess, can happen in that age group. And in the age gap of 35 to 55 years, there is involution of the breast. So the density of the breast becomes less, and there are more chances of uh, fibroadenosis or CA breast or similar conditions.
Okay, so that is a basically your ND classification. In examination, you will be getting for 3 or 5 marks question for ND, and also examiner will ask you what is ND and all. You have to explain ND. So what are the reproductive, what are the based on like developmental, what are the reproduction, what are the involution disorders. So based on that, that age is important. Okay. Why
Yes.
this sex is important? Female sex or male sex? Any significance why sex is important?
Uh, Estrogen is associated with these diseases or breast cancer, and it is more commonly in females. It occurs more commonly in females, so that's why a sex is important.
Okay. So any breast disorders which are more common in the females. Suppose if some male patient, old age male patient is coming with you with complaints of lump in the right breast,
Yes.
and same age female patient is coming, 60 years old female patient, she is also coming with lump in the right breast. So which
Yes.
one you want to operate, or which one you want to tell the prognosis of the patient? Your prognosis is good among both the patients.
Uh,
Did you get my question, Nitin? Same age male and female patient is coming with lump in the right breast, old age patient. In which patient you want to tell the prognosis, or which patient you want to operate earlier? Any idea?
uh, sorry, sorry, sir.
Okay. So basically, if male patient is coming with a CA breast, so basically male patient, they'll be having lesser in the size, or there is a lesser in the stoma, lesser in the fibrous tissue. So there is a higher chances of invasion of your chest wall, higher chance of metastasis in the male patient compared to female patient, and your male patient are having poor prognosis compared to female patients. So you want to operate earlier in the both the patient, but male patient you have to give the preference. Okay,
Okay, sir.
because of less trauma component in the male breast tissue, there's a higher chances of invasions in the male breast tissue compared to your female breast tissue. Or in any old
Okay,
age
sir.
patient or any male patient coming with a lump in the breast, there is higher chances of malignancy in the male patients.
Okay, sir.
Okay. Suppose if male patient, if old age or any old age male patient is coming with you bilateral enlargement of the breast and that are painful. Old male patient, he is coming with you with bilateral breast enlargement and both the breasts are painful.
Uh, Sir, it can be a breast abscess.
Both the breasts at a time. So what you want to counsel the patient, and what will be your differential diagnosis if someone is coming in old age with both breast enlargement and both are painful? You want to think in terms
Uh,
of malignancy or you want to think in terms of benign condition?
mm, I think it will not be a benign condition, considering the old age and
Okay, so old age, when old age is coming, bilateral breast enlargement and both are pain. See, malignancy, no, it will less likely it will produce the pain. So malignancy, like most of the time, it will produce a lump. Okay, so
okay, sir.
pain is the least feature of the malignancy. So you'll be not having that much of typical pain in the malignancy unless and until some secondary
Okay, sir.
complication is there. So any
Okay, sir.
patient coming with lump or pain, that is more likely benign, and there
Okay,
are
sir.
rare chances of higher advanced malignancy and all, but most of the time it will be benign lesion. So whenever old patient coming with bilateral breast enlargement and both the breasts are painful, you have to think in terms of senescent gynecomastia.
Okay, sir.
Okay, so that is a hint for you, painful. If there was a painless, you have to work. Obviously, you have to work up the patient. But if it was painless, then you have to think in terms of malignancy more. Okay.
Okay,
So
sir.
your diagnosis will be senescent gynecomastia. So what is the importance of
Yes.
residency? Any
Uh,
idea why residency is important?
uh, Residency can give us idea about socioeconomic status as well of the patient.
Okay. Apart from that,
Uh, s- Sorry, sir.
okay. So basically, CA carcinoma is breast, it is more common in the Western population
Okay, sir. Hmm.
compared to our India and all. No? So it is more common in the Western population, and where CA breast is, you can see in the rarer
Mhm.
or rarest form. Which countries there will be least chance,
Mhm.
least cases you will get in the CA breast? Which countries?
Hmm.
So you will be having less
So,
incidence of CA breast in the Japan.
okay, sir.
Okay, so it is more
Japan.
common in the higher socioeconomic status and in the more in the Western population.
Listen. Yes.
So what is the ratio of Western population? You will get 1:8 females you will get in the Western population, but over in India you will get 1:25.
Okay, sir.
Okay, so in India there is a high incidence of 1:25 patient, but in Western population you will be having incidence of 1:8. Okay, so that is
Okay,
your
sir.
residency. Residency is important, and also residency is based
Yes.
on your treatment aspect, which investigation you want to advise the patient, which mode of treatment you want to give to the patient. Okay, so your
Hmm.
patient is your 54-year-old patient. He is coming with the complaints of lump in the right breast. So what are the differential diagnosis of lump in the breast?
Uh, Fibroadenosis, breast
Mm,
abscess, pylorus tumor.
basically, no fibroadenosis. You will be not having typical lump.
Yes.
You will be just having some nodularity.
Okay, sir.
Okay, so you will be having vague nodularity in the breast. You will be not having proper lump in the fibroadenosis.
Lump. Okay,
Okay,
sir.
so there won't be proper lump in the fibroadenosis. So what are the differential diagnosis of lump in the lump in the breast? Anyone? What are the differential diagnosis of lump in the breast? So one is your carcinoma. Then
Mhm.
okay, in
So
young
that
age you will be
this
not this any
in
general that
young
what
age,
in young you will get. Hello, Nitin.
hello, sir.
Yeah, yeah,
Am
yeah.
I audible, sir?
Yes, 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 yes.
Uh,
So
in,
what are the differential diagnosis
in
of lump
young
in the
age,
breast? Yes.
serious voice is not audible, sir. Sorry.
Yeah, yeah. In young age.
So can you repeat the question, please, sir?
No, basically, what are the differential diagnosis of lump in the breast?
In young age, fibroadenoma,
Okay,
uh, uh, in, uh, in pylorus tumor,
okay.
carcinoma breast,
CA breast. Okay, next.
So ductal papilloma.
Ductal papilloma. It will be predominantly it will having symptoms of your any bleeding, nipple discharge basically.
Okay, so
See, basically, if you get any trauma, you will be having hematoma. Okay.
hematoma,
If
fat
you
necrosis.
traumatic fat necrosis. Okay. During
Yes.
pregnancy, you might get galactosile, or if you have
Galactose. Yes.
patient is having fever, abscess, you'll be having breast abscess. So that also produce a breast lump.
Yes.
Okay. So you if
Yes.
any kind of if in the middle aged patient you'll be having cyst in the breast cyst.
Mm.
So you should be knowing the causes of lump in the breast. So associated pain. So why this pain is important? What are the types
Uh,
of pain you will get in the breast?
Sir, normally there is no pain in malignancy. Uh,
Okay.
Usually, pain is associated with inflammatory condition or any infection.
Suppose if your middle age or young age female patient, she is coming and telling that during menstruation she is getting pain. So what it is called as?
Uh,
cyclical mastalgia.
Nostalgia.
So that is a cyclical mastalgia. So if there is a
Cyclical
pain,
nostalgia.
if there is a pain in the breast, basically that is mastalgia. You have to first differentiate it to whether it is associated to the reproductive cycle, menstrual cycle, or non-menstrual cycle. So based on you have to classify whether it is a cyclical or non-cyclical mastalgia.
Yes.
Okay. So what are the causes of
Yes.
non-cyclical mastalgia?
Mhm. Breast abscess.
Okay, one is your breast abscess. Next, you told no one your fibrocystic disease.
Pilots do.
Phyloids less likely. Then
Um,
Mondor's disease.
okay, that is Mondor disease. Next, what is Mondor disease, Sapna? Nitin.
Sir, it is thrombophlebitis of superficial veins of the breast.
Okay, superficial thrombophlebitis of the veins of the breast. You will be having cord-like sensations of the veins.
Cord-like thickening of the veins, most commonly thoracic veins.
Okay, next, what is your teeth syndrome?
Uh, Tietz syndrome is costochondritis of the third or fourth costochondral junction.
Okay, so what is the most common cause of your non-cyclical mastalgia? So answer is your scapulothoracic bursitis.
Okay, sir.
Okay, if there is any scapulothoracic area, there, no, if there is any inflammation of bursa, you will be having referred pain from your shoulder joint to your breast. So that is your scapulothoracic bursitis. So cyclical mastalgia, there is a non-cyclical mastalgia. Cyclical mastalgia you will get in the you are basically you are told of fibrocystic disease.
Fibrosis.
So patient will be having fullness in the breast, pain in the breast, and more likely that to more than lump they will be feel the nodularity in the breast. That will be usually in the bilateral.
Okay, sir.
Non-cyclical mastalgia you have to think other causes also. So you have lump in the right breast and associated pain since last 15 days. So since 1 year she is having lump and pain since 15 days.
Yes.
Okay. So next slide. So see, basically, these are the terms upper outer quadrant, lateral quadrant. This is the examination part. You have to tell only on the
Okay, sir.
upper outer aspect or inner aspect or middle upper inner aspect or lower inner aspect. You have to tell in the words, not in the upper lateral quadrant, upper inner quadrant. Those are the examination findings.
Okay, sir.
Okay. Since 1 year, your patient is having lump in the right upper
Yes.
outer aspect of the breast, which was initially pea size, now currently progressed to a size of 1. So some examiner, they'll expect you to mention the size. What was initial size
Okay, sir.
approximately? What is the current size? So better to tell in the both the layman word. You have to tell in the pea or ball size, or you have to tell in the whether what was the initial size before, what was the size now. Okay. So
Yes.
since 1 year the lump is the same in the size or it is progress, how much it is progress that is important, no? Whether it has become doubled in the size and all.
Okay, sir.
So what do you think if the lump is progressing since 1 year?
Sir, it's slow growth.
So basically it is slow growing.
So it can be malignant tumor.
Okay. It could due to old age you can think it as a malignant one.
Malignant tumor. Yes.
Okay. But it is you can tell it as it is a form of it's a gradually progressing.
Okay, sir.
Okay. Why and there is why this history of pain is important since 15 days. Why it is throbbing type of pain. So basically where you will get throbbing type of pain, Nitin?
Sir, in ductal papilloma.
No, throbbing type of pain is your classical of any abscess.
Okay, sir.
So you are telling your patient is having lump in the right breast since 1 year
Hmm.
and she is having throbbing type of pain.
Yes.
And, and in one hand you are telling your diagnosis is your malignancy.
Hmm.
So because malignancy usually it will be painless.
Yes.
So throbbing type of pain you'll get basically in the abscess. Suppose if you are thinking in terms of abscess, which abscess will produce
Hmm.
like this kind of history?
Hmm. Sorry, sir.
Anyone?
Sorry, sir.
No, no, anyone apart from within, anyone?
Or in chronic conditions,
What are the chronic conditions?
like it may be in TB or granulomatous diseases.
So it may be tuberculosis. So suppose Sapna, if it is a tuberculosis of breast, so how tuberculosis of breast will spread?
Or it may be a direct, not a direct spread, maybe hematogenous or lymphatic.
So one is a basically one is your basic less likely hematogenous, one will be from your lymph nodes. Okay.
Hmm.
Another one is from your directly from your parietal cavity, parietal pleura.
Okay, sir.
Okay.
Okay,
So
sir.
parietal pleura, if there is any rib cage infection, okay, tuberculosis. So basically, tuberculosis will affect which part of the breast, whether intramammary or retromammary part.
Sorry, sir.
So basically, tuberculosis will affect your retromammary part.
Okay, sir.
So tuberculosis will start from your chest wall or rib cage. So it will produce in the retromammary areas. So tuberculosis is usually cold abscess, no?
Yes, sir.
So patient will be having lump in the breast since the long duration of the history. Patient will be having simultaneously or tuberculosis pulmonary manifestation, and because of any superadded infection, basically tuberculosis, no, it is your cold abscess. So because of your superadded infection, they will be having kind of throbbing type of pain. So one will be your differential diagnosis of your tubercular breast you should rule out. Next is your what is Jessica disease.
Sorry, sir.
So your Jessica disease, your chronic periductal mastitis.
Okay, sir.
Okay, most commonly seen in the smoker, most commonly seen in the middle-aged patient. Okay, so that is your chronic periductal mastitis. In that also patient will be having lump in the long duration and multiple discharging sinuses will be there more than lump. and patient will be having signs of abscess, and that is your chronic, both recurring abscesses. If you drain one abscess, that will resolve. Again, patient will be having abscess. Again, patient will be having abscess. You have to drain it. Again, patient will be having multiple abscess. So that is your chronic periductal mastitis called as your Jessica disease.
Okay, sir.
So, ठीक है, Nitin. Apart from your CA breast, you have to think in terms of Jessica disease is mostly seen in the smoker patients. Okay, so you have to think in terms of your tuberculosis of breast. Next one is your malignancy. Next one is your less likely Jessica disease. That is chronic periductal mastitis.
Okay, sir.
Okay. So why?
Yes.
So basically, any breast, no, any CA breast, they'll be having mild dull aching pain, not like throbbing type of pain.
Okay, sir.
So if suppose if your patient is telling, sir, I was having a dull aching type of pain, but suddenly after 2 days they did some procedure, so now I am having throbbing type of pain. You told no, she underwent one day before some procedure. She underwent some procedure, no, Nitin.
Hmm.
So she underwent what
She
procedure?
underwent crooked biopsy, sir.
Okay, basically she underwent some kind of biopsy. So because
Yes.
of biopsy, she might be having some type of pain because that is procedure, no? So
Yes, sir.
she is having mild pain because of that biopsy, not per se your not per se your lump. If you are thinking in the aspect of malignancy, if you are thinking in the
Yes.
aspect of tuberculosis of breast, that will be secondary suprarenal infection. Then you will develop throbbing type of pain.
Yes.
What is the history of recent weight loss? How much is the weight loss and how much it is the recent? You have to mention specifically in the exam.
Okay, sir.
So what was your weight
She has.
loss? So see, whenever you go to the ward, you ask to the patient, oh, whether you have weight loss. All patient will tell you,
Yes.
yeah, yeah, I have weight loss. So
Hmm.
that is not important for you. So you have to ask the history of weight loss, whether it is in the significant weight loss. So what is the significant weight loss?
So weight loss can again indicate malignancy.
No, no, what is significant weight loss?
Significant weight loss. So more than 10 kgs lost in. Uh,
10 kg or 10%?
sorry, sorry,
10%.
10%, sir. Sorry, more than
10%.
10% of weight lost in past 3 months.
Okay, so more than 10% of your past 3 months, that is your significant. You have to ask the history specifically.
Okay, sir.
See, what are the differential diagnosis of weight loss associated with your lump in the breast?
So first one is malignancy. Then it can be tuberculosis as well.
Okay. Any other thing, treatment wise?
Sorry, sir.
Sir, if she has undergone some chemotherapy, radiotherapy for the past malignancy.
So, if she has underwent some past history of any chemotherapy or radiotherapy exposure for any kind of malignancy, or per se she is having taking treatment for chemotherapy for your breast malignancy. So that is how it leads to your weight loss. Okay.
Okay, sir.
So why you want to ask this history of no history of rapid increase in size?
In malignant conditions, the tumor grows slowly or gradually. Uh,
Hmm.
so rapid increase in size. If there is a history of rapid increase in size, then we can exclude the malignancy.
So in this patient there is no history of rapid increase in size. So you want to rule out
Yes.
malignancy?
Sorry, sir.
In this patient, no, there is no history of rapid increase in size.
Yes, sir.
So you want to rule out malignancy?
Uh, Sir, it's one of the factors. So
So see, basically, no, there is rapid increase in size that will tell you about how the malignancy is behaving, which kind of malignancy, whether how much it is aggressive.
okay, sir.
You will be not completely ruling out malignancy or malignant or benign lesion. You will be just ruling it is malignant and how it is malignant, how much it is aggressive.
Okay, sir.
Okay, to rule out that aggressive nature, you are asking the history of rapid increase in size, not to rule out your malignancy from benign condition.
Okay, sir.
Okay, so just to know about the aggressive nature of your malignancy. So, what are the aggressive malignancy in the breast? What are the see basically you'll be having types of breast carcinoma, no?
Yes, sir.
So, what is the most dangerous or what is the most aggressive breast cancer?
Sir, is it medullary type?
Medullary breast carcinoma, okay. More than that, not intraductal carcinoma.
Sir, triple negative breast cancer.
Triple negative breast cancer. More than that, so your inflammatory, so your inflammatory breast carcinoma is that is your aggressive one.
Okay, sir.
Okay, your inflammatory breast carcinoma. Your say basically when you are having Feyer's tumor, no.
Yes.
So Feyer's tumor. What is the Feyer's tumor?
Virus tumor is a cystic fibroepithelial neoplasm in a breast, uh, which
Ah,
shows
okay.
cystic
That is one.
lesions in breast with leaf-like projections uh, associated with rapid increase in size, pain,
अरे मैं इतने
and
ज्वाइन किया था इसको. अरे एक मिनट रुकना.
inflammation and redness over the skin.
किससे किया था? एक मिनट रुक मैं करता हूँ इसमें. एक मिनट रुक. अरे इधर इधर.
That's
Nitin, just 1 minute. I'll 1 minute. I'll connect back.
okay.
Hello.
Yes, sir.
Yeah, yeah. Basically, the fibroadenoma, no, basically fibroadenoma is kind of your soft tissue tumors only.
Okay. So,
Okay, so basically fibroadenoma will be used based on you will be having based on both your stromal component and your predominant will be your stromal component compared to your epithelial component. So if there is any stromal component, if there is any rapidly growth will be there, no, you will be getting your it will behave like your sarcoma.
yes.
So sarcoma, if there is a long-standing history of your piloid tumor, so it will be gradually progressing since 2 to 3 years. Suddenly, it will start developing rapidly, no. So that is the your differentiation into your sarcoma.
Okay. So,
Okay. So one is your inflammatory breast carcinoma, that is your associated with rapidly proliferative, and next one is your piloids, differentiating into your sarcoma.
okay. So,
Okay. Basically, we are joined with Bhargavi also. Bhargavi, hello, Dr. Bhargavi, are you there?
Am I audible? Yeah, yeah, yeah. I'm there.
Okay, you are audible. So basically, we have just started with the 52-year-old female patient. She is having a lump in the right breast since 1 year, and she is having throbbing kind of pain since 15 days.
Okay.
Nitin, can you go to your first slide?
yes.
Okay.
Next slide.
Can we go to the next slide?
Yes.
Okay.
So Nitin, what you want to ask? Similar swelling in the opposite breast.
Sir, in any conditions, if similar condition or swelling or any carcinoma has occurred in opposite breast, there will be uh, metastasis over the uh, contiguous uterus.
So you
What is
want to
where does bilateral breast cancer arises, or in which malignancy of the breast you will suspect opposite side lesion also, Nitin? First thing, in lobular breast cancer, you should always feel suspicious the opposite side might get involved. Or whenever there is a tumor in the inner quadrant of the breast, there's 33% chances of it going lymphatic metastasis to opposite breast. So
Yes, ma'am.
whenever, yeah, the ductal carcinoma, the P53 gene mutation, sorry, the lobular carcinoma, the P53 gene mutation, and also whenever the breast is involved in the inner quadrant. What is the most common location of CA breast? Which quadrant?
Outer upper
Why?
quadrant. More breast or breast tissue is more dense over
Okay,
outer
okay.
quadrant.
Nitin, why, where does a throbbing kind of pain specific in breast?
It appears in inflammatory condition or abscess.
Abscess, mastitis, or
Abscess.
what more? What more? In cyclical mastalgia also they tell that throbbing kind of pain only.
Hmm.
You have not any described relation of pain in relation to menstrual cycle. Means you have not ruled out cyclical mastalgia, right?
Yes, ma'am.
Yeah, you have to mention no history of breast pain in relation to the menstrual cycle.
Okay, ma'am.
Yeah. Okay, can we go with, if this is over, can we go to the next slide?
one more point, Nitin. See, if your patient is coming, no,
Yes.
she is telling you she is having a lump in the both the breast.
Okay, sir.
And she's asking you, doctor, which one is the first? Like she's not remembering which lump she has the seen the first. Okay, so she's asking
Hmm.
you which one is the primary, which one is the secondary.
Hmm.
So you are telling no right. Suppose if you are telling right breast, metastasis left breast. She's asking you, doctor, how you are telling which breast is your primary, which breast lump is secondary. What you want to tell the patient? How you want to classify this one?
So, so we will look at
She is
the
not.
look position of
She,
the lump.
no, no, she is not remembering the exact date. She has seen both the lump at the same time. She is asking you, doctor, which one is primary, which one is secondary.
Yes, so by the location of the lump, in, when
Location
the
of the
lump is
lump.
in medial medial side
No,
of the breast, uh, middle and lower quadrant of the
see,
breast,
if there is a lump in the medial aspect, no, there is higher chance of metastasis to left breast.
metastasis
That,
to the contralateral.
that is the different thing. I'm asking you. She has seen the both the lump at the same time. She's asking you which one is primary, which one is secondary.
Sir, can we differentiate it by checking the lymph nodes status of
No.
both the sides? Okay.
See, basically, first no, you have to see the size. Which one is your bigger in size?
Yes.
Okay. First is your size criteria. Then next one is your you have to do the biopsy. After doing biopsy, you know which one is having your more aggressive nature. So that is your primary. Okay.
Yes.
So this is called some classification name that is homework for you.
Okay.
Okay. So suppose if your patient is having no, there is specific criteria is are there. So which one is primary, which one is secondary? First one is your size criteria. Next one is you have to do the biopsy. So as Dr.
Yes.
Bhargavi told you, if you are having lobular carcinoma in situ, so that is predominantly you'll be having lump in the, both the breast. So what
Okay.
no history of discharge from nipple. Some exam no, they will say this is a discharge from nipple is your sign. This is not the your symptoms and all. So you can ask the history of discharge from nipple. So what are the different types of nipple discharge you will get?
There can be clear serous discharge, uh, bloody
Clear.
or blood stain discharge, uh,
Uh, see,
black
basically,
or clear.
see, when someone is asking you discharge from the breast or something, you know, first you have to tell the discharge from the surface,
Okay.
directly going inside the breast. First, you have to tell the discharge from the surface. So, what are the differential diagnosis of discharge from the surface? Any idea, Sapna or anyone? What are the different?
No, sir.
What are the your discharge from the surface? What are the conditions get discharge from the surface? So, you'll be having in your Paget disease.
Paget's disease.
Okay, in Paget disease, you'll be having discharge from the surface, and also from if there is any eczema. It's a kind of dermatitis. If there is eczema, dermatitis, okay, or Paget disease, you'll be having discharge from your surface.
Yes.
Next you have to classify whether discharge is from your single duct or discharge from your multiple ducts. Okay, discharge from your single duct, then you have to classify which kind of discharge you are getting. So now tell me, what are the types of discharges in from you will get from the single duct?
Clear serous discharge in case of rectal papilloma, blood stain discharge in case of carcinoma or duct ectasia, black, green, or muddy kind of discharge in case of duct ectasia, discharge in case of mastitis.
See, basically, when you are having discharge from the single duct, that is your blood is discharge, no? So that is your kind of duct papilloma. Okay. So if there is any serous discharge, if you are getting serous discharge from multiple ducts, that is your fibrocystic disease. If you're having multiple duct, if you're having any discharge from the single duct, that is your greenish color, that is your more likely turbulent discharge, that is your duct ectasia.
Okay, sir.
Okay.
You call the discharge of carcinoma as 4S, I think. It's serous, spontaneous, single duct discharge. The 3 S's of, I think, malignancy. Serous,
Yes.
single duct, and spontaneous discharge.
Yeah.
Okay. So if you're having any spontaneous, serious kind of in malignancy, basically you will get all the type of discharge. You can get bloody
Yes.
discharge, you can get serous discharge, you can get purulent discharge. So malignancy exception. But if you're having serous and you are having spontaneous discharge from single duct, that is your more likely malignancy. If you're having discharge from the bilateral, no, so it will be mostly in the benign conditions. If you're having discharge from the single side, that will be more likely your malignancy. Suppose in the reproductive age group, okay, if you are having milkish discharge from the both the breast, but your patient is not pregnant or she is not lactating. Basically, you will get milk discharge from the both the breast in your during lactation or during pregnancy. Okay. If your patient is not pregnant, if your patient is not lactating, what will you think, Nitin?
Do you suspect any other causes of galacturia? Any endocrine cause? Anyone? Endocrine cause? Any?
Prolactin, prolactinoma.
What is the
So,
most common cause? One more most common cause. Prolactinoma and hypothyroidism.
so you have
Okay.
to think in terms of prolactinoma and hypothyroidism.
Okay, sir.
Okay, sir.
Okay. So basically, nipple discharge no, you'll get for 3 marks or 5 marks, and you have to basically you have to classify from the surface, from the single duct, from the multiple duct, and based on that, your types of serous, a bloody discharge or greenish discharge, and after that, you have to write the how to evaluate for nipple discharge and all. So there is no history of redness or warmth of breast. Why you are asking the history of redness or warmth of breast?
In inflammatory conditions, there is
In this in
redness.
this age group, 52-year-old patient, you want to rule out inflammatory conditions.
Any specific type of malignancy you want to rule out?
Inflammatory.
Yes, inflammatory breast cancer.
Breast cancer.
Okay, basically you
What
want
more?
to rule out.
What all do you see in inflammatory breast cancer? What are the different things you see in inflammatory breast cancer? Matlab, okay, redness and warmth of the breast is fine. What more things you will see in inflammatory breast cancer?
Ma'am, PUD orange, more than one third area PUD orange.
Yes. What more? What more? PUD orange, greater than one third of the circumference. Then satellite nodules.
Okay.
Any more? What is the third thing? Three things you will see. Third one is the homework, okay? PUD orange, satellite nodules. What is one more thing you will see? To call it inflammatory breast cancer. If any of these three things are present, you will label it as inflammatory breast cancer. Okay. Why you are asking any history of any wound? What does this wound signify?
Any kind of trauma and or maybe any kind of ulceration or function can suggest aggressive or aggressive disease, aggressive
Okay.
carcinoma.
Okay. It can be ulceration. It can be fungation. It can also be a simple breast biopsy, also, right?
Yes, ma'am.
Simple breast biopsy. You will have small like 0.5 mm ka wound.
Yes.
Yes. ठीक
But
है,
you told me
can we go?
your patient underwent trochanter biopsy, Nitin. But how she is not having any kind of wound now?
Sorry, sir.
Okay, basically she underwent some procedure. Basically she might be having some kind of wound.
Yes.
Okay, for inflammatory breast carcinoma, there is a Hagenson criteria is there. ठीक है, डॉक्टर भार्गवी told, no, that is homework for you. Higginson criteria is there.
But the Higginson is not being used nowadays. He have described it when all these things we were not in. I think in 1960s or 70s he have told all this criteria. But now we have three things which we use mainly. It's the Pudea orange, the satellite nodules, and third one you have to uh, read and tell us. Can
Okay,
we go to the next slide?
yes, yes, yes.
Yes.
So basically, history of similar complaints in the family, no, you have to write in the family history. So no history of early menarche, menopause, ठीक है, fine. What is early menarche?
More exposure to the estrogen.
No,
Throughout
what is
No,
early monarchy? Before what age you call it as early monarchy?
uh, initiation of menstrual cycle before the age of or before the age of 8 years of life. It's early
8 years.
8 years, sir.
Anyone? Let this discussion be like one to one, not like monotonous. Anyone who knew the answer, just tell us. So now we can cut off all the wrong thoughts. What all present for everyone. Everyone, please do participate. What is early monarchy?
Ma'am, is it before the age of 13?
Yes, yes.
Okay, so
Why? What does? Okay, what is late menopause? When do you call it as late menopause?
cessation of menstrual cycle at the age of 47, which is an average age of menopause in India.
Actually, they tell 50 to 53. It depends. Even though the early age of menarche it is different for the Indian population, and it is also different for the Western population. Based on the country which they stay, based upon everything, they'll tell some people tell 53, some people tell 55. But now they have the statistics tells it has decreased to 47, 48. That is not important. You will have that standard age in every country based on that you'll see. But what is the importance? Any statistics which is related to this early menarche and late menopause, which is signifying breast cancer? They tell for every 1 year decrease in menarche means if at all the patient who have to get normal cycle at 14 years, imagine the patient is getting 13 years, there is almost 5% increased risk of breast cancer. Same with menopause. If the patient has normally every person in that area has menopause at 50 years, imagine the patient is having menopause at 51 year, so it increases the risk. So for that it is important. Okay.
So what is the definition of menopause, Nitin? When it you
Cessation
called
of
as
menstrual cycle for more than 12 months.
okay, so that is a more than 1 year with associated with your symptoms of menopause. Vasomotor symptoms are there, no? Okay, so that are the symptoms associated. That is called as your menopause. So we'll
Yes.
discuss family history here only. What is the important of family history?
So, family with genetics, 5 to 10% of breast uh, cancer are familial due to BRCA1 and BRCA2 gene mutations. So
What are BRCA1, BRCA2? Are they sporadic or what? Or they what kind of mutation are they?
they are familial, ma'am. BRCA1 and BRCA2 are familial gene mutations, and P53 is sporadic.
Okay. What is difference between sporadic and familial? Sporadic, familial, and hereditary. Anyone?
Sporadic is by chance and not due to inherited mutations, but
Okay.
familial is due to inheritations.
Then what is hereditary?
Basically, there are three terms: sporadic versus hereditary versus your familial breast cancer. So what is your sporadic? So which one is the most common amongst sporadic, hereditary, or familial? Your sporadic is your most common. Then what is your hereditary breast cancer? So basically, hereditary breast cancer is a carcinoma of the breast with if there is any inheritable gene identified in the specific familial pattern. As you are telling, no, BRCA1 gene, BRCA2 gene. Okay, there
Yes.
might be P53 is there. So P53 gene it is called as Lee-Frommeni syndrome.
Yes.
If there is any mutant gene mutation is there, that is your Cowden syndrome. So basically, if you are having any inheritable identified gene mutations, that is called as your hereditary breast cancer.
Okay, sir.
Okay. If there is no evidence of any hereditary identified gene, but the family is sharing common environment, as suppose if there are family, both the family members they are get exposed to some kind of radiation. If their family members they are consuming high kind of saturated fatty foods, in that family you have examined for any germline mutations, but germline mutation comes to be negative. They are sharing common environmental risk factor, but there is no identified germline mutation. That is called as your familial breast cancer.
Yes.
Okay,
So
hereditary
this
breast
can be
cancer.
used anywhere. This can be used anywhere. This can be used in any other cancer. If at all they ask what is familial cancer, what is hereditary cancer, this is not only pertain to breast. This can be pertain to colon, any other malignancy. Okay.
So hereditary, you have to identify your germline mutation, but there is no germline mutation. Only they are seeing common environmental factor. That is your familial breast cancer. Can you specify more about your BRCA1 and BRCA2? Where the gene locus for BRCA1 and BRCA2? Chromosome number for BRCA1 and BRCA2?
Chromosome number 17 for BRCA1
Okay.
and chromosome number 14 for BRCA2.
14.
So
13, sorry.
7,
13.
17 and 30.
13. 13.
Male breast cancer is common in which BRCA1 or BRCA2?
Mm, BRCA2.
Triple
Your
negative? ER negative, PR negative, HER2 negative, which is called triple negative. It is common in
BRCA1.
It's BRCA1.
hmm?
Is it BRCA1?
BRCA1 or BRCA2? Okay, that is homework. HER2 is common in which BRCA1 or BRCA2? Why
so
did you
basic,
ask the history of
so basically, no, like triple negative or basal type, you will be getting in the BRCA1. So your BRCA1 is no having it is a like poor prognosis compared to your BRCA2. And the BRCA1
Yes.
also you'll be having see basically no you'll be having 50 to 60% of breast cancer risk in the BRCA1, whereas 30 to 40% risk in the BRCA2. But you will be having 40% risk of ovarian cancer in BRCA1 and 30% in the BRCA2. But triple negative or basal like you will be developing in the BRCA1. So BRCA1 is always associated with your poor prognosis compared to your BRCA2.
Okay, sir.
Okay, so that is the
and
important of.
BRCA2 will be HER2 positive, so you have some treatment towards BRCA2. So you because there is some treatment now, generally BRCA2 has a little good prognosis. It's like that.
So suppose Nitin, if one patient is coming, no, she is telling you, I'm having BRCA1 or BRCA2 positive. So what you want to advise them? What is your investigation of choice?
Uh,
If I am your patient, I am coming and
No,
telling, no, sir,
what you
I'm
want
having.
to ask is, it is it is already identified BRCA1 BRCA2 mutation. Do you want to do USG? You want to do mammo, or you want to do MRI?
So what is your investigation
if
of choice?
if the age of the patient is more than 40 years,
No,
then
No,
no, no.
we are not talking about the general population. The patient is already very high risk. The patient is already having mutation.
okay,
Now she came to you. So what do
then
you?
then MRI will be the investigation of choice.
Yes,
So MRI is the investigation of choice, and you have to advise the patient bilateral nipple sparing mastectomy, prophylactic mastectomy.
Yes.
Nitin, what are the indications of MRI?
Uh, age first one is this if the BRCA1 and BRCA2 positive.
What age? What age? I didn't get you. Why ageless? For every patient you will do. If age is less, you will do. You can do USG, right? Why
Yes.
mammo? Why MRI? Sorry, why MRI? You can do USG, right? What are the indications for MRI specifically? Okay, according to you, it's BRCA1, BRCA2. What more? I have already told. Breast implant, right, Sakshi? Next.
Recurrent disease.
Recurrent breast cancer. Okay, fine. What more? Three. I have got three till now. Any previously operated cancer, if at all there is scar. Okay. The fifth one. Anyone? Any bilateral breast cancer? If there is multicentricity to rule out if it is a high risk patient, or if at all it's high risk patient. What are high risk patients? Whoever known mutations are there, wherever the family history, first generation family relatives are involved. For all those patients, if it is less than 25 year, you will do MRI. MRI is only done in high risk patients as a primary thing. You will never do in a normal patient. Okay.
Okay. Okay.
So basically,
To know
for
about
Dr.
the scar, after surgery, MRI is very good. To know about the implant, MRI is very good. To know about in BRCA patient, which is high risk patients, MRI is very good. What more? Bilateral breast cancer, MRI is very good.
Age
if
less
there,
than 20.
if there
High
is
risk
any
patients with age less than 25 years.
if there is any lobular carcinoma incident is also there, no, that is also producing a bilateral breast cancer. So
Lobular
in
carcinoma.
lobular carcinoma incident also you have to do MRI.
Okay, sir.
Okay. So your early menarche, like one was done, history of nulliparity, absence of breastfeeding.
We have forgot one more thing. If there is discordant imaging between mammo and USG, if at all there is a discordant in imaging between mammography and USG, then you will do MRI to confirm what is the problem you are having.
Okay.
Yeah.
So Nitin, why history of this bone pain, or sorry, why history of radiation exposure? Which radiation you are asking specifically?
Any X-rays of chest?
No. No. Is there any specific thing where you will give radiation to chest wall and anything? X-ray will cause specific.
Radiotherapy.
Radiotherapy for specific thing which you cause. If at all you are giving radiotherapy to leg or something, does this cause CA breast?
No.
Which radiation? X-ray doesn't cause CA breast. Mammo doesn't cause CA breast. CT also doesn't cause CA. Which specific radiation you are asking? Matlab, for which cancer the patient might have received radiation which might cause CA breast? I think that's what the question is.
Yeah, yeah, yeah. So basically, no, for Hodgkin's lymphoma or any kind of lymphoma, no, you will be having mantle radiation. So mantle radiation, basically, you will be having radiation exposure. Like Hodgkin lymphoma, you will be getting at the thorax, or you'll be having. So for that, you will be getting exposure for the mantle radiation. So history of previous radiation for mantle radiation is important, not your X-rays and all.
Okay, sir.
Okay. So why history of bone pain is important? Which bone pain you are asking specifically?
Uh, Bone pain, in case of complications or metastasis, there will
No,
bone pain.
which bone pain you are asking specifically?
Uh, in in vertebrae or
Which vertebrae?
Is asking indirectly what is the spread of CA breast.
sorry, sir.
Which vertebrae gets involved in CA breast? Thoracic, lumbar, cervical, anything specific? How does it get involved? involved? Lumbar, Sakshi, right?
Lumbar.
Femur, humerus, okay. First lumbar vertebrae, then head of femur. Fine. In lumbar vertebrae, why does it go to lumbar vertebrae? Any specific thing through
Because the
which
your breast is at your thoracic level, no? Why it is going for your lumbar areas? Why not thoracic?
Socho, if it goes at the breast is at thoracic level roughly, Socho T5, T6 level, it's there. It goes to the intercostal veins, which are wall-less, and it goes to some other veins. What are that plexus called? So okay, it go to the Batson plexus. Still, it doesn't invade the thoracic vertebrae. Still, it goes to the yeah, right, Sakshi. Still, it goes to the lumbar vertebrae. Why?
Nitin, any idea? See, basically, no, it is common sense because your lumbar vertebra, no, because of gravity, your tumor cells, it will go and your deposit your lumbar vertebra level, and also your Batson plexus are there. No, Batson plexus basically your prevertebral plexus, and those plexus are your colles plexus. Okay. So inferiorly, it will go and it will be having communication with your prostatic plexus, and superiorly, it will be having communication with your cranial apna dural sinuses.
Okay.
So basically, your internal thoracic veins are there, no?
Yes.
Through internal thoracic veins, which drains your memory areas, through internal thoracic vein, it will go to your Batson plexus. Those are your prevertebral plexus, and those are your valgus plexus. So basically, your lumbar areas, no, they'll be having your Batson plexus, and those are in the bigger size, lumbar vertebrae, and also lumbar vertebrae at the lower region compared to your thoracic. Because of gravity, no, your tumor cells will go and deposit your specifically L4 L5 junction. From there it can go to the prostate, or from there it can go to your brain. So this is how ca breast will metastasis to your brain or your pelvic areas. This is how
Okay.
hematogenesis spread will happen. So specifically you want to ask the history of any back pain or history of pain at the your joint. Specifically, if you want to ask the history of any joint, hip joint, you want to ask the history of pain. Okay.
Okay.
So
Okay.
breathlessness, think for pulmonary metastasis, you want to ask the history of breathlessness. Swelling of arm, why you want to ask the history of swelling of arm?
Uh, Metastasis to the lymph nodes, axillary lymph nodes can
So
cause
then, what happens to arm if it's metastasis to axillary lymph nodes?
swelling of the arm. Let's say
Why
due
does arm get swelled if at all lymph nodes are involved? So
poor
the
drainage of the lymph.
poor drainage of the lymphatic system, right?
Yes,
Yeah.
due to enlarged lymph nodes.
Yes.
So if you're having no
Due to
like,
invasion, distortion of the lymph node happens, no?
Yes,
Because of the metastasis. Yes.
yes, ma'am.
so what is cancer and cures? So which kind of lymphedema you are expecting in this patient, primary lymphedema or secondary lymphedema? What is Stewart syndrome?
Second.
It's
Sir,
very because of what? Of cancer, na? So it's primary or secondary?
secondary.
Secondary. What?
Yes.
So your
What is cancer inclusion?
primary lymphedema, no, basically primary lymphedema is your idiopathic. So the cause is not known. So secondary lymphedema, if it is associated or like if it is associated with malignancy, if you are operated the patient, you have removed all the lymph nodes of the axilla, there is no drainage, you are getting lymphedema, that is your secondary lymphedema. What is your cancer in
Yes.
cuirates, or what is your Trevor syndrome?
Sir, development of lymphangiosarcoma due to long-standing lymphedema in the arms, which may be due to malignancy or after the removal of the axillary lymph nodes.
After mastectomy or after lymph nodes? That is called. That is called what? That is called what? It is cancer and cruiser. What or what?
Stewart syndrome.
Okay. Then what is cancer and cruiser?
Aggressive involvement of the chest wall.
Aggressive involvement of the chest wall. By what? It's nothing but the cutaneous metastasis of the cA breast.
Okay, ma'am.
Yeah. That the soldier will have that armor, right? That chest armor. The
Yes, ma'am.
metastasis is that sort of thing. Yeah.
Yes.
So the Stewart syndrome and the cancer inclusive. Where do you see night sweats and fever? Why do you ask the history of night sweats and fever?
Sir, ma'am, to rule out TB, tuberculosis.
TB and what more? Anything
Ma-
specific in breast? There is an
to
entity called
rule
as
out lymph.
granulomatous mastitis. There is an entity called as granulomatous mastitis. You have to rule out granulomatous mastitis. And at this age group, why night sweats and fever is important? Anything?
Ma'am, to rule out lymphomas.
Breast may it's unlikely. Okay, no. Generally to rule out lymphomas. Any specific condition? Any specific breast pathology? Periductal mastitis, ductal tissue also presents with such sort of thing only. Night sweats and fever.
Okay.
Okay,
So
ma'am.
you had to rule out tuberculosis, to rule out
Yes.
granulomatous mastitis, to rule out ductectasia.
Periductal mastitis and
Periductal mastitis, ductectasia. Okay.
ductitis.
Okay. Let's go to the next slide.
Okay, ma'am.
History of true cut biopsy. One day ago. No history of that. Okay.
How she is knowing it
Continue.
is true cut biopsy only? Nitin?
Sir, there was small wound.
So it could be FNAC. How much you are specifically are telling it is true cut biopsy. So exam no. Basically you have to tell only sir she has underwent some procedure. So examiner will ask
Okay,
you
sir.
what kind of procedure it was FNAC or true cut biopsy. Basically FNAC it will be very much smaller in size. But true cut biopsy the wound size will be almost 1 into 2 centimeter or 1 into 1 centimeter. So basically you have
Okay,
to
sir.
tell only she has underwent some procedure. Let examiner ask you what procedure and all. So your DM, thyroid, asthma, hypertension, no history of allergy to food or any drug intake. So basically, past history, you want to ask the history of any previous OCP intake, oral contraceptive pill. So why you want to ask the history of oral contraceptive pill?
You have not mentioned history of OCPs, history of you have didn't you mention separate obstetric history?
Sorry, ma'am. I forgot to
You have
write that.
yeah.
I've
In
asked
CA breast,
OCP and
no, in CA breast you have to mention specific menstrual history in female. Even though thyroid case you have to mention menstrual history. In menstrual history you have to mention age of menarche, age of menopause, number of childbirths, number of
I've
time.
I've mentioned this on next slide.
ठीक है, yes. Let's continue.
So why this history of OCP is important, Nitin?
Sorry, sir.
Uh,
OCP history is important. Why OCP history is important?
why OCP history is important?
Uh, high dose of estrogens due to OCP or long history of taking OCPs and HRT for more than 5 years or 10 years can be a risk factor for breast cancer.
So how much is
3
the risk?
years. Relative risk. What is the relative risk? Any idea?
So that is if you are having combined OCP pills, estrogen, progesterone, you'll be having 20% risk, relative risk of getting CA breast, carcinoma breast. If you are taking only estrogen pill, the relative risk will be lesser, but combined pills are having 20% risk of carcinoma of the breast. Okay.
Okay, sir.
So next, so basically, past histories you want to ask whether she had underwent any hysterectomy, along with that any oophorectomy, any surgeries. So that is the important because see basically when you are taking past history,
Sorry.
take past medical history and past surgical history. She has underwent any procedure before. This personal history is normal, but only personal history you have to ask the diet, which kind of diet she is taking, whether it is high saturated fatty acids, fatty foods and all. So that is associated risk. And history of smoking, history of alcohol, that is important. Why history of alcohol? How history of alcohol is important? How much is the relative risk of taking alcohol consumption? Any idea, Nitin, what is mild drinking, moderate drinking, and severe drinking? So basically,
Two,
no
three.
mild drink. What? Anyone? So if they are taking, no, basically 1 to 2 drinks per day, that is mild drink. 3 to 4 moderate drink, and more than 5 drinks, that is your severe drink. They are taking. So based on that, no, mild 1 to 2, moderate 3 to 4, severe more than 5 drinks per day. So mild is associated with almost 1 to 2% risk, moderate is 3 to 4, and your severe drink is associated with more than 10% risk of carcinoma breast relative risk.
Okay.
So that is the history of smoking and alcohol is important. Next,
Breastfeeding done for how much time? You have not mentioned. You have not mentioned normal delivery. Okay, you have not mentioned about the abortions.
There
No,
was
no.
no abortions.
Okay. You have to mention now you have you the G formula, you have the GPA formula. You can write the GPA formula. And you also have to mention about the age of first childbirth.
Okay, ma'am.
Age of first childbirth you have not mentioned. OCP usage you have not mentioned. In history of abortion you have not mentioned. What more things? If the cycle is regular, the cycle is regular, every month she's having a cycle or she's having any regular cycle you have not mentioned. If at all cycle is regular, if the cycle is normal cycle, whether the flow is normal and what is how many days she's having cycle, that is also important. You are all ruling out all the hyperestrogenic conditions, right? So it can be an ovulatory cycle. You know an ovulatory cycle, right?
Yes, ma'am.
The patient will not have any pain. The patient only menstruates for 1 to 2 days. It is also important. So everything about the menstruation is important for CA breast. So you have to mention about everything. You have to mention age of menarche, then age of first childbirth, how the patient cycles are, if the patient is having any abortion, after first childbirth is the patient how many months the patient is lactating. Why lactation is you are asking lactation?
Uh,
There will be lactation amenorrhea, right?
yes, ma'am. There will
So
be
the
lactation amenorrhea and
so the
estrogen levels are low during that
so if the
period.
patient will not have cycles, so estrogen
Yes.
will not be there. Then you have to ask whether cycles are regular. Then you have to ask about the age of menopause. All these are important.
Okay, ma'am.
Yeah.
next.
You have also asked about the surgery of hysterectomy. Any history of tubal ligation also.
Yes.
Tubal ligation invariably tells them that the patient can't get pregnant again. That's why.
Okay.
Yeah. Family history. Okay.
Not contributing. Family history not contributing.
See, basically, no, you should not write there is no association with BRCA1 or BRCA2. You have to write there is no history or suggestion of BRCA1 and BRCA2 related malignancy in the family members.
Okay.
Or
Okay, there is
just write
no,
the family history is not contributory. Bus.
Okay.
so there is no history of any BRCA1 or BRCA2 related malignancies in the family members. You have to tell this specifically. Next.
So general examination.
Okay, next, proceed.
So patient was examined in a well-lit room with prior consent. She was conscious, cooperative, well-oriented to the time, place, and person. The respiratory rate is 16 per minute with normal chest movements. Pulse rate is 80 beats per minute, measured in left radial artery in a sitting position, having normal rhythm and volume. Blood pressure is 130 by 90 mm of Hg, measured in left brachial artery in a sitting position. The weight of the patient was 58
Nitin,
kg.
hello, Nitin.
Yes, sir.
Tomorrow we'll do this examination and this management part, if you are okay with it.
Sorry, sir.
tomorrow can we do examination and management part if you are fine with it, if you are free?
If
Yes,
you
sir.
are okay, tomorrow we'll continue. I think most of the people might get exhausted by now. That's why.
Yes, sir.
Because it's breast examination, no, we'll do properly.
Okay, sir.
Okay.
So for me, just do something. I'll ask you 5 questions. Find answers for those 5 questions. Okay.
Okay, ma'am.
Okay. About the mammography, I have already kept in the group. I think you people have sorted the answers. Anyone who can answer the questions? About mammography. What are the different views of mammography? Anyone? Okay. All the questions of mammography, and I want you to know about what are the malignancies BRCA1, BRCA2 are involved. If at all the patient has BRCA1 and BRCA2, what are the different systems gets involved in BRCA1 and BRCA2? Okay. Then I want to know about you. I want you to know about what is sentinel lymph node biopsy. How does sentinel lymph node biopsy done? Okay.
Okay.
The fourth, yeah. The fourth question is, what is wait, wait. What is oncoplastic breast surgery? Just tell me what is oncoplastic surgery. I just want you to understand what is oncoplastic breast surgery. And the fifth one is what are the indications of radiotherapy in CA breast? These are the 5 questions. The oncoplastic breast surgery, the questions of the mammography, indications of radiation in CA breast, what is sentinel lymph node biopsy, and where does you do sentinel lymph node biopsy? Okay.
Okay,
So
ma'am.
these 5 questions, we'll discuss them at the end of tomorrow's class.
Okay.
We'll discuss it. And we'll be continuing the tomorrow for examination and rest of the part.
Okay, ma'am. Okay, sir.
Okay. Okay. Thank you.